Nice. Hmm. All right. Let's get a couple more students in here. We start this off. Definitely.
Doctor, a question not regarding with studies, but do you have any idea when is the last chance to apply for next step, for example, next match?
I'm not sure. I can find out for you though. I can find out for you. Definitely.
Thank you, because it's tricky. I know after this step two, there is a one OET for
Yes.
international
And
graduate.
I've heard of some people failing that exam a couple of times. It's just that they get things wrong because they want you to have like a certain score for different fields. So definitely watch out with that.
Mm,
And yeah, I would find out. I'll find out for you today though. I'll let you know
thank you.
for sure. Definitely. All right, let's see. Let's see. We got two people already. I think it's good enough to start. Let's start this off. Let's start this off with question right here. So it says here, the beneficial effect of this new drug on normal cells is likely achieved by bypassing the cellular requirement for which of the following enzymes? All right. So let's take a closer look at this question. Here we're seeing all these enzymes basically in front of us. We have to understand these are high yield enzymes, I would say. Definitely. All right. Judas says a 6-year-old boy with ALL is brought to the office for a follow-up examination. He is receiving high-dose methotrexate therapy. A drug is added to the patient's medication regimen to decrease the toxicity of this therapy to normal cells. So there's a beneficial effect here. Now, they're adding basically. Do you guys know what drug is actually added? What drug is
Local,
added?
leucovorin, maybe.
Leucovorin, right? I would agree with you. Definitely leucovorin. So let's look at that. That is the pathway. That's one of the most important pathways. And I don't know why, but you'll see in the first aid, it's such a small section. This is the pathway of de novo pyrimidine synthesis, right? Pyrimidine synthesis in particular, de novo. So let me just show you guys really quick. This pathway right here. Most likely they added leucovorin. Leucovorin, right? in order to replenish, in order to not deplete the folic acid, in order for you not to have a depleted level of folic acid. So let's take a look. First off, this step right here is one of the most important steps. We understand this, we know this. Thalidomide synthase is going to catalyze this reaction in order for you to have the dihydroxy TMP. Okay, what drug inhibits thalidomide synthase in humans? Do you guys remember? What drug inhibits thalidomide synthase in humans, and what is it used for? 5-FU. 5-fluoral uracil. Definitely. Perfect. And yes, it is used for colon cancer as one of those major uses that we could actually say it's used for. Yes, basically colon cancer. 5-FU. Now, remember this. In fungal cell, particularly, let's say Cryptococcus, there's a drug. Yes, it basically can become 5-FU in fungal cells via the enzyme cytosine deaminase. Cytosine deaminase. This drug is called flucytosine. Flucytosine. This drug is used for which organism? Do you guys remember? Cryptococcus, right? Cryptococcus neoformans. So yes, Cryptococcus neoformans. Do you guys remember the actual treatment? You have to give flucytosine alongside with what other drug? Amphotericin B. Yes. Alongside with amphotericin B. That makes perfect sense. You give that for about 2 weeks. Then you switch them off to what drug? Fluconazole. Good. Good, good. Yes. Good. Everybody remembers. That's awesome. That's awesome. All right. So there is a trick here. There is an important trick when it comes to the administration of leucovorin and thalidomide synthase. Very high yield type of concept. Do you guys remember? Giving leucovorin and also having given something like 5-FU. Yes, definitely. There is this paradox, this weird thing that does happen. So basically, one thing. In this question here that we were looking at, it was a patient that is being treated with methotrexate. So it is a rescue type of drug for methotrexate. So if we're looking at leucovorin, let me grab leucovorin and show you this weird paradox. So try to remember this. Leucovorin. It works as a rescue, yes, for normal cells, right? And it rescues the normal cells from methotrexate type of toxicity. Remember that methotrexate can inhibit dihydrofolate reductase. This drug, this leucovorin, also has the power to potentiate the cancer killing effect of 5-FU. So leucovorin, it's a rescue of normal cells. Normal cells. Also, you're going to see that it can also potentiate. It also potentiates when it's given with 5-FU. So rescue in the terms of methotrexate, but it potentiates, definitely potentiates when given with 5-FU. Good. 2 effects there that you guys should know. Definitely keep that in mind. So yes, that is important. All right. That's what they wanted to know. That's what they wanted you to basically get down when it came to this type of question here in particular. They wanted you to know the effect of rescue potential that it does have when it comes to drugs like methotrexate. So again, remember, dihydrofolate reductase is inhibited by many different drugs. We always talk about this. When it comes to toxoplasma, we say pyrimethamine. Right? Remember the treatment for toxoplasmosis? You guys remember? Pyrimethamine. What else? Pyrimethamine with sulfadiazine, definitely. And if a pregnant woman is IgG positive, spiromycin decreases torch infection. Decreases torch infection, right? With toxoplasmosis. Remember, toxoplasmosis has diffuse calcification in comparison to CMV. Both will have chorioretinitis. Both of them will have chorioretinitis, torch infection, CMV and toxo. Both of them have chorioretinitis, but toxo has diffuse calcification, while CMV has periventricular calcification. Good, good. You guys remember this. You guys know this. That's awesome. That's great. All right, let's continue. Let's continue. So yes, also I should mention, let's look at these enzymes. Let's look at all these enzymes. Let's get these enzymes down. Dihydrofolate reductase, we just spoke about it right now, how there's a whole bunch of different drugs that inhibit this. In prokaryotic cells, you guys remember what drug is inhibiting dihydrofolate reductase? Think about that. The answer, of course, is TMP. TMP, yes, TMP. Remember, TMP can cause a lot of different types of symptoms that are kind of crazy. Remember, it can cause hyperkalemia. It can cause hyperkalemia by inhibiting the ENaC channel. That is seen, that is true. So hyperkalemia, you tend to have peaked T waves, right? Peak T waves, that is one thing that you can tend to see. Peak T waves with hyperkalemia. There's also something called sign rhythm. Sign rhythm. That's basically when the QRS and the T wave are together. There's no distinguishing the two. You also tend to see that with hyperkalemia. Not sinus, but sign. But anyways, just letting you guys know, definitely hyperkalemia is something that can happen with TMP. Remember TMP SMX, that combination can also cause bone marrow suppression. That's another issue as well that's seen. Keep that in mind. Super important. So yes, look at these enzymes here. Methionine synthase. Methionine synthase. So methionine synthase is supposed to convert homocysteine to methionine. And it uses tetrahydrofolate in that sense. Homocysteine to methionine. That will not be the answer. Yeah, it has a cofactor of B12. Remember that? Remember? Cofactor of B12. That's one thing that needs to be used. Now, look at pyruvate decarboxylase. Do you guys remember pyruvate decarboxylase? I always make this ridiculous type of mnemonic when it comes to entering the mitochondria. I don't know if you guys remember, but pyruvate decarboxylase. Well, first off, pyruvate decarboxylase, I think pyruvate carboxylase, from what I remember, is used in the sense of what you're saying. Definitely. Decarboxylase is used in some other type of pathway. I think it's used in the pathway of acetaldehyde and alcohol, to be honest. That's the type of route that it goes through. So I'll show you right now in the first aid. Let me see if they pull that up. Let me show you guys really quick. Decarboxylase. Yeah, do not confuse this with carboxylase. Carboxylase. Yeah, that is kind of tricky. I don't think they even have it here, actually. But it is used in that step where you're doing that alcohol synthesis to acetaldehyde. That is one thing that is used. Gluconeogenesis uses pyruvate carboxylase. That is true. So let me just show you pyruvate carboxylase. Very important step for gluconeogenesis, the actual first step. Remember, in order to enter the mitochondria, we always say carboxylase. You need a car to go into the mitochondria. So remember, pyruvate is able to try to enforce gluconeogenesis in the sense that pyruvate itself cannot, it's an irreversible type of step when you make pyruvate from PEP. PEP. Whenever you make pyruvate from PEP, you can't make pyruvate go back into PEP. It has to take now a longer alternative route. So what I'm just telling you is for gluconeogenesis, there's a carboxylase type of enzyme. Yeah, this answer choice said decarboxylase. That has to do with alcohol synthesis. That's different. So PEP here, let me just show you guys something really quick, just so you guys can remember, some type of memory type of tool you guys can use. Pyruvate needs a car to enter the mitochondria. So here for gluconeogenesis, the point is to get pyruvate to PEP, but it cannot naturally just become PEP. It has to go an alternative route. And this route includes the idea of going inside the mitochondria, right? Of actually becoming oxaloacetate. Oxaloacetate. And you do this with carboxylase. Carboxylase. So remember that. Because after you make your oxaloacetate does have the power to become PEP. That's how you override this irreversible step. That is how you override the irreversible step. Yes. Okay. Now we're talking. Let me see. Okay. I see the chat now. I see the chat. Now we're talking. Basically, you're saying, yes, the idea of basically making this become PEP. First, just remember carboxylase. So yeah, there's a lot of different types of cofactors that is able to play a role here. Let's talk about that as well. But one thing that I would tell you, something to just take into consideration right now, put it into your mind, is whenever you're entering the mitochondria, you need a car to get in there. Now, why do I say this? Because even when you have fatty acid, for example, so yeah, we'll talk about all the cofactors as well. But really quick, even if you have fatty acids, do you remember how can you get fatty acids inside the mitochondria in order to do beta oxidation? Beta oxidation. Carboxylases uses ABC, ATP, biotin, CO2. So yeah, I would tell you the pyruvate carboxylase, it does use CO2 and it will have to use the ATP. It will have to use ATP. So yes, definitely carboxylase, biotin for carboxylase. That is true. Biotin. And it is going to also use ATP. So definitely vitamin B7, biotin, super important there. Keep that in mind. But one thing I'll tell you as well is fatty acids. If you look at fatty acids making its way into the mitochondria, do you know it also needs a car? They also need a car. So you do have the carnitine shuttle. Carnitine shuttle. Yes. Carnitine shuttle. So that kind of makes you think, okay, we need a car to get inside the mitochondria. And then PEP to oxaloacetate need GTP. Well, PEP, well, you mean oxaloacetate to PEP. Because oxaloacetate has to become PEP in this step. I think that's what you mean. Right? There you do need GTP, yes. There you do need GTP. So here, yes. All right, that's a good one. That's a good one as well. They do test for these smaller things. So let's put this down. GTP is needed for oxaloacetate to become PEP. And then yes, biotin is needed for pyruvate to become oxaloacetate. That is perfect. That does make a lot of sense. You also need ATP here for this one. So that's perfect. And then yeah, here you have the carnitine shuttle. Definitely. You're going to use a lot of NAD and FAD when it comes to beta oxidation. That's one thing. Remember, the whole process of beta oxidation is just the idea of grabbing a very long chain, carbon-carbon chains, and then shaving it down to 2 carbon units, acetyl-CoA, in order to make either ketone bodies or to shove them into the TCA cycle. That's the idea there. Yes. Okay, yes, in TCA, yes, there's a lot of small things in TCA that you do need to know. I would definitely tell you in the TCA cycle. Let's open that up. Let's take a look at the first aid TCA cycle, how they put this up. In the TCA cycle, one thing to take into consideration, there are steps where you're basically going to make your GTP. There's the steps of FAD. I remember the fumarate step, right? That one is the one that's going to use FAD. So you do need to remember the small steps here that produce FAD, that produce GTP, things to that sense. So succinyl CoA to succinate, as you can see here, GTP. Yes. It's kind of crazy because they do ask questions just based on this alone. In TCA cycle, it is important to know those type of steps. Remember that isocitrate dehydrogenase. I'm sorry, alpha ketoglutarate dehydrogenase. There is the whole tender love and care for Nancy. I don't know if you guys remember, but these are a list of cofactors that are utilized in pyruvate dehydrogenase. Pyruvate dehydrogenase, in order to become acetyl-CoA. Yes. So before this, acetyl-CoA is the one that will go into the mitochondria and will serve this important step here to become citrate. You do have a couple of cofactors that you do need to understand in this sense when it comes to making your acetyl-CoA. Acetyl-CoA can come from pyruvate. It can. But you do need vitamin B1, tender loving care for Nancy. So tender loving care for Nancy. NAD, FAD, the idea of CoA, lipoic acid, and then thiamine. This is basically vitamin B1. Vitamin B1, that would definitely make sense, right? So one thing that is important, these dehydrogenases are super important. Isocitrate dehydrogenase, here you will need the same type of combination. You'll need the same type of combination, the tender loving care for Nancy, right? Alpha ketoglutarate dehydrogenase, you need the same type of combination of cofactors. That's something else to take into consideration. Definitely remember that. Yeah, pyruvate dehydrogenase, especially pyruvate dehydrogenase. Remember that. That's why alcoholic patients that tend to have a lower level of B1, we give them B1, B4 dextrose. B1, B4 dextrose. We prepare the cofactors before we supply the actual glucose, the actual sugar. That way it could metabolize neatly. All right, now let's look at these steps, these important steps here. Malate to oxaloacetate. So what's the product that goes on here? Here you have NADH, right? NADH. Fumarate to malate. So, well, hold on. Succinate to fumarate, I should say. Last time I said fumarate to malate. No, the fumarate one is involved in FAD, yes, but as a product. So succinate, fumarate, FADH. FADH, definitely. We already said succinyl CoA to succinate, GTP. Alpha ketoglutarate to succinyl CoA, this one right here, NADH. And then isocitrate to alpha ketoglutarate, NADH. Look at that, guys. Look at all this stuff here. Super important to know these small little cofactors, these small things I'm telling you, because they might ask questions just based on that. Let me screenshot it and put it right on the chat so everybody can take a look at that. Okay. Definitely where I put a star, that's the cofactors. That's the cofactors. Tender love and care for Nancy. All right. That makes a lot of sense. That's good. Just remember, you need a car to get into the mitochondria. And what's my example? Fatty acids going into the mitochondria for beta oxidation. Carnitine shuttle. Pyruvate for gluconeogenesis is pyruvate carboxylase. Carboxylase uses biotin as a cofactor and ATP. Okay, good, good, good. I feel like we haven't gone through bio chem for a while. So definitely try to keep all this information, practice it a little bit so you don't forget it. All right, let's continue. Let's continue. We just got that from, I believe, pyruvate decarboxylase, but okay. Thymidine pyrophosphate, that's the activation of thymidine. Thalidomide synthase, this is this major enzyme here that's used in order to catalyze this reaction. Now, if anything here is inhibited, if you inhibit anything here, you guys do remember, you can't have an anemia, right? What type of anemia do you get if you inhibit any kind of step here that's giving you pyrimidines? Megaloblastic type of anemia, right? Megaloblastic anemia. Now, do remember one thing. Megaloblastic anemia, very high yield concept here with megaloblastic is B12. B12 deficiency. So just remember, B12 deficiency does have severe combined degeneration. Definitely. Hypersegmented neutrophils as well, right? Extra small lobes that you'll see. Now, severe combined degeneration with B12 deficiency. Remember, this one here will have sensory issues first. So look at the chronological order of the clinical presentation of this. Sensory issues, then motor. So I'm going to put it here, sensory, then motor, and then, of course, more types of dementia, more types of mental issues. So sensory problems, just do remember that the sensory issues do include spinocerebellar. Spinocerebellar, that's where they get their ataxia, right? Remember as well, motor, cortical spinal tract. Cortical spinal tract, that's upper motor neuron issues. Now, dementia, yes, I'm just putting it here as the chronological order, but do remember that D stands for dorsal column. Dorsal column, yes. So do remember the whole aspect behind it, dorsal columns located back here. Definitely, we draw it out. You're seeing this is spinocerebellar. You have your posterior and your ventral spinocerebellar. Then you have your dorsal column located back here. And then, of course, cortical spinal tract is here. Cortical spinal tract is here. And then just in case, spinal thalamic would be here. Spinal thalamic. Just a quick drawing of the spinal cords, just so you guys could remember all these crazy types of symptoms and issues that the patient can have. Definitely with B12 deficiency, that is seen in a lot of neurodegenerative types of issues. So much so that if you want to diagnose your dementia, they do the mini mental state exam. And after you do that, you're supposed to rule out like reversible causes, nutritional types of causes, and B12 is one of the things that you're supposed to check for just in case. Remember that spinocerebellar? They have issues like ataxia. They have a wide-based gait. Wide-based gait. That's what you tend to have with spinocerebellar. Wide-based. This is different than Parkinson. Different than Parkinson's. When it comes to Parkinson's, they have a narrow type of gait. Narrow-based type of gait, right? Now, remember, the major thing though with spinocerebellar is the ataxia. You can definitely see ataxia with these type of patients for sure. So keep that in mind. When it comes to cortical spinal tract, upper motor neuron issues, spasticity, hyperreflexia, we know this, right? Babinski sign is going to be positive. That's upper motor neuron. Dorsal column is vibration, proprioception, and fine touch. Yes, but remember they do have positive Romberg when we're looking at dorsal column. Why is that? It's just because, yeah, if you look at dorsal column, it utilizes our vision as part of a system to detail our proprioception. So when the patient closes his eyes, you're hindering a major piece of, let's say, a major part of the system that it utilizes for proprioception. And if you have dorsal column issues and you also close your eyes, expect the patient to fall over on the side of the issue. Well, here's bilateral. So you just expect the patient to fall over. That's a Romberg sign positive. Closing his eyes. would cause him to lose balance. Okay? Keep that in mind. Keep that in mind. All right, perfect. Good. Let's continue. So yes, awesome how we can include all this. We can talk about all this and everybody knows. That's good. Let's go jump into another question for sure. Let's look at something even tougher. Let's see, something a bit tougher here. I'll put this question right here. We'll read it together. Try to answer it to the best of your abilities. But here this question states cells in the mass produce a hormone that binds to which of the following? All right, so this is a specific question. They really want to know that the cell is going to bind what? Like you're supposed to know exactly. So let's see. It says here, a 9-pound male newborn is delivered in the hospital, 40 weeks gestation, to a 28-year-old gravid woman. Pregnancy and delivery were uncomplicated. All right, 40 weeks, 9-pound baby, right? Everything's looking normal. All right, so it says here, APGAR scores were 8 and 9 at 1 minute and 5 minutes, respectively. Examination of the newborn tongue shows a small blind pit in the midline located near the intersection of the anterior 2/3 and the posterior 1/3. Ultrasonography of the neck shows a mass attached to the hyoid bone. Okay, cells in the mass produce a hormone that binds to which of the following? So this is a really good question. This is a really good question because yes, you would have to first know what type of cell are they talking about? What type of system are they talking about? Yes, they are talking about thyroid, right? We are talking about thyroid second messenger system mainly. So hopefully you guys remember second messenger system for thyroid. I'll show you guys something really quick. Let me pull this up. Let me pull this up for you guys. You guys can see. Thyroid system is one that I do enjoy because it's so interesting how different it is. Yes, that's exactly what I was about to say, Shavnal. Exactly what I was about to say. I was about to show you guys the difference in second messenger system for each. It's like, for example, they're asking you here the second messenger system involved when it comes to T3, T4. So I would like to show you guys all the intracellular types of second messenger system. I'll show you guys with a small mnemonic. This is such a high yield topic for step one. I'll tell you guys that a lot of it it's so high yield because you find this in different subjects. It's found in micro, it's found in onco, and now you're seeing how it's found in endocrine as well. This right here, PET, DCAT, these are all the intracellular receptor types. Intracellular receptor types. So what is the issue here? Yes, you're going to see that one thing they all have in common here is that they're all permeable to the membrane. They're all permeable to the membrane because they're coming from cholesterol. Cholesterol, look at the names, progesterone, estrogen, right? They're lipophilic, except for T3, T4. This one comes from an amino acid. You guys remember what's the derivative? What amino acid derivative? Tyrosine. Tyrosine, yes. So tyrosine here is an amino acid derivative that is basically giving you T3, T4. That's a protein. Proteins are not typically lipophilic. So there is a transport system for T3, T4, and it is able to enter through the membrane. Now, T3, T4, when it does enter, where does it actually bind? Well, you guys said it yourself. You guys said nuclear receptors. Yes, it does bind to the nuclear receptors. So you'll notice one thing that is super important. It's able to actually upregulate. It's able to upregulate sodium, potassium, ATPase channels. It's able to upregulate and cause a higher demand within the basal metabolic rate of the body. So you're going to burn more calories by doing the same type of activity. That's basically what T3, T4 is doing. It's forcing you to utilize more energy without actually enforcing or doing tasks that require more energy. You're just upregulating sodium, potassium, ATPase channels. So it increases your basal metabolic rate, definitely gives you more of a boost in your sympathetic system. Now, of course, I have to ask you guys the classic question, which is total peripheral resistance. Is this increased or decreased when you have high levels of T3, T4? Total peripheral resistance. Decreased. Yes, decreased. So this is hard for a lot of people to understand, but it is decreased. It is decreased as much as somebody would want to say it's not. I'll show you guys exactly why. And this is why you can find something called wide pulse pressure in patients who have thyroid storm. Wide pulse pressure in patients with thyroid storm. Let me explain to you. So what typically happens in these type of scenarios is that since your body is producing, it's basically using more energy. I shouldn't say producing. It's using more energy. No. Good question. Good question, Miriam. No. Instead of binding cytoplasmic type of receptors, no. It goes directly to the nucleus and it starts to activate. It's more like some type of transcription factor, behaves more like a transcription factor than anything. Rather than influencing the nucleus, it actually binds to nucleus. So here you see how it says nuclear receptors rather than cytoplasmic complex or anything of that sort. That's another thing. So this list here of intracellular receptor includes receptors that are intranuclear and receptors that are intracytoplasmic. So T3, T4 is intranuclear. It does act more like a transcription factor in that sense. So good question, definitely. Now, since you are producing more energy, you tend to produce more of these metabolites. This is the whole chalk system. Yes, you have more CO2, higher levels of CO2, higher levels of hydrogen, adenosine, lactic acid, and I hate to use potassium, but yes. The point is that when you have a higher level of all these, you are going to cause more peripheral dilation. Right? Hopefully that makes sense. If you have more peripheral dilation, your total peripheral resistance overall would be lower. A lot of people tend to forget this. Same thing happens in exercise. When you're exercising, let's say you're doing a cardiovascular type of exercise, you're running. You're producing more CO2, hydrogen, lactic acid. By producing more of this, you're decreasing the total peripheral resistance in order for you to replenish all these metabolites with actual energy, with ATP, with oxygen. So yes, this is a very confusing thing for a lot of people, but do remember this. So we said TRH is using GQ, second messenger system, while TSH uses GS, second messenger system, and then T3, T4 is actually binding to the nuclear receptors. So look at how awesome that is. They changed their second messenger system according to what type of protein they are in the first place. So yeah, this is awesome. Remember this, guys. Remember this. It is important because, yeah, it's seen everywhere. It's seen everywhere in that sense. So what happens when you actually start to, let's say, activate the DNA? Do remember, when you activate the DNA, you will basically try to transcribe. Remember, transcription of proteins. Yeah. You have basically transcription factor. Remember, you do have promoters, enhancers, silencers. A lot of people are clueless about these things. It's like, well, what do they mean? What is it? The promoter region is next to the area that you will transcribe. And remember, RNA polymerase are involved with transcription. Polymerase are involved in transcription. It's just that RNA polymerase can't really find the area at all. It depends on transcription factor to bind the area first. RNA polymerase 2 basically is going to make your mRNA. That's the idea behind that. Definitely, that's what tends to happen. So the transcription process basically is all about enhancing the segment that you want to copy. Promoter region is next to the segment that you will copy. You inhibit all the silencers, and then you're able to transcribe. Once you have a proper transcription of mRNA, remember, in order to leave the nucleus, CPS, Child Protective Services, capping process, poly A tail, you add a super long tail of A, a whole bunch of adenosines, poly A tail, and then, of course, splicing. Splicing introns and exons. Introns stay inside, exons will leave. That's the idea behind that. And once you have your mRNA, remember, you have to basically transcribe it by finding the cytoplasmic ribosome, which is made of rRNA subunits, right? 60S, 40S. You guys remember that? That's the eukaryotic type. And once the mRNA enters, you will be able to have your start codon, the whole AUG, right? 4-mil methionine. Hopefully you guys remember. One thing that I will tell you though is that in prokaryotic cells, they need Shine-Dalgonill sequence in order to find the ribosome. Shine-Dalgonill sequence in order to find the ribosome. With eukaryotic, you don't really need the Shine-Dalgonill sequence to find it, but you will expose, yes, you will expose something called Kozak sequence once you bind. Kozak sequence will be there once you bind. That's just the difference. Like, for example, we have nucleus here. You'll see that the prokaryotic cells will not have to process their mRNA the same way because they don't have a nucleus that will basically get in the way of their mRNA. So their mRNA specifically has Shine-Dalgonill sequence in order to find their 30S. 16S subunit of the 30S is actually complementary to the Shine-Dalgonill sequence of mRNA. mRNA has a little sequence here that's able to stick to 16S. That's for prokaryotic. But in eukaryotic, we're able to actually bind and find it easier because we do prepare the mRNA a lot better. But Kozak sequence gets exposed after you bind, after you find it. But okay, continuing. Definitely all this makes sense. That's good. That was a good question. Now, another thing, what was the actual issue, the actual diagnosis here with this patient? Ultrasound of the neck shows a mass attached to the hyoid bone. This patient basically had midline issues, right? Midline neck, just below the hyoid bone. That's like the tongue base. I don't know if you guys remember the foramen cecum. Thyroglossal, yes. Thyroglossal duct issues, right? That makes a lot of sense. So one thing to remember about this, I remember it's midline. How do I remember this? Let me just show you guys some tricks real quick. Look at the throat, let's say, and there's a T right here. I could remember this T is in the middle. This T is in the middle. It falls right in the middle. That does let me know that it's midline. And this T, it actually, when you swallow, it actually moves. When you stick your tongue out as well, you'll find some movements because it's attached to the base of the tongue. So thyroglossal cyst is midline and it moves when you swallow. That's the whole idea behind it, okay? That is the whole idea behind it. All right, how about a branchial? Yes, the branchial cleft cyst. It is in the lateral neck. So you can definitely remember branchial. is in the lateral neck. So I look at it like a B, basically in the lateral. So yes, it's basically you find it in front of the sternocleidomastoid. It does not move when you stick out your tongue. It's basically lateral. That's an easy way to differentiate between the two. All right, that's the most common type of differential that you should know. All right, good. Now there's a dermoid cyst as well, so be careful. Dermoid cyst. It could also be midline. The dermoid cyst could be midline, but it does not move with the tongue. Doesn't move with any like swallowing or any movement. So dermoid is not thyroglossal. It's in the middle, but it does not move. Dermoid is stuck. All right. Good. Hopefully that makes sense for everybody. Hopefully that makes sense. All right. Now, there are also other smaller tricks to try to remember how to differentiate all these types of issues, definitely. The dermoid type of cyst, it is painless. But I would say another type of congenital issue I'll mention, I know I mentioned this the other day, was the comparison. There was a comparison of the vascular rings and the laryngomalacia. Yeah, that is another one too as well, the cystic hygroma. The cystic hygroma is something that you should see at a very early stage. It's more of a lymphatic problem. So it's seen like in the posterior, I believe it was like the posterior triangle. You can actually find this. It transluminates. It's a lymphatic issue, definitely. Turner has it as well. That is true. Definitely. I'll show you guys another trick. Behind the sternocleidomastoid, I believe yes. I believe it should be behind because it's the posterior triangle. So we look at the posterior triangles of the neck. Let me show you guys. Posterior, they use the sternocleidomastoid as a origin point. Posterior triangle behind the sternocleidomastoid. Yes. So let me just show you guys how it looks. Here it goes. I don't like that they didn't put posterior anterior. Instead, they put some names like occipital. That makes it a lot more confusing. It's better when they actually, okay, yes. When they actually give you triangle, anterior, middle, because it is divided within triangles. So yes, the one that is behind the sternocleidomastoid is the posterior triangle, the one that you're seeing here, right? The one that you're seeing outlined right here. That's the posterior hygroma. It's a lymphatic type of issue. And it should be seen that way. Keep that in mind. Now, continuing. Something else I should mention is congenital issues. So there's something very important when it comes to congenital problems, like for example, vascular ring. There's a vascular ring that does get formed. So definitely it's like an aortic arc type of abnormality that you can tend to see. Vascular ring type of formation. There's also laryngomalacia. I don't know if you guys heard of these two types of conditions. So let me put them here on the screen actually, so it can make sense. I'll teach you guys a nice way to remember how to differentiate these easily, so you guys do not get confused. So really quick, vascular ring, when you look at it, it looks like a V, right? So that V has two dots. So I do remember these two dots dictate everything. Inspiration, so it has an inspiratory stridor, inspiration, and expiration, expiratory stridor. Spiratory stridor. So it has both. All right, another thing as well is that it will have feeding issues, will have feeding problems, but it also has respiratory problems. So both systems are affected here when it comes to vascular ring type of formation. Now, something else I would tell you, of course, it gets worse when feeding and we're swallowing and all this, but the position. You'll notice extension. So if you extend, it tends to get better whenever there's extension of positioning. You notice that it'll get better. Now, this is not the same. Like when you look at, for example, I'll give you an example, laryngomalacia. Laryngomalacia, this L, if you look at it like this, we can put an I on it like this. It has inspiratory stridor. And it does have more respiratory issues than feeding problems. Okay, inspiratory stridor, it's like one type of issue mainly, which is respiratory problems. So when he's crying, it gets worse. You can see cyanosis when he's crying or like that. Okay, that should make sense. That's in laryngomalacia. Remember that. Supraglottic region is very weak. That's what causes these kind of problems. So yes, perfect. Get it down. Laryngomalacia, most common cause of the infant type of stridor. Improves when prone, upright. Resolves by itself 12 to 18 months. Perfect. All right. Continuing. So keep this in mind as well. That's just a clue in that sense of how to differentiate these nicely. Let's look at another question. This was definitely a thyroid duct issue. Now, do remember that thyroid itself is related, thyroid storm, let's say in general, for patients who have thyroid storm, is related with arrhythmias. You guys remember what arrhythmia is related to thyroid hormone being very high? AFib, right? AFib. Okay, AFib is true. Definitely. Hopefully you guys remember everything we went through when it came down to arrhythmias. Because how would you treat a patient who has AFib due to thyroid storm? What would be the treatment? Propranolol. Yes, propranolol. That is correct. Now that we're talking about arrhythmias a little bit, let me just sprinkle one question to you. Just one question to you. I'm curious to see if you guys would pick the right answer. Very curious, actually. Let's see, because it's something that we talked about, but I don't think we actually seen in any question that we have done. But I got this question the other day, and I did kind of think of you guys. I said, hey, I wonder if my class, my people would get this right. My tribe, my crew, let's see. I wonder, would you guys be able to get this right? This is something that we talked about a lot, but we haven't really seen it. So if I present this question to you guys, read it and try to get the answer. Type in your answer if you think you know what it is. And we'll discuss this for sure. Okay? So yes, this is a challenge. This is a challenge for you guys. Hopefully you guys can get this. Definitely. If you know the answer, just type it in there. It's okay. Nice. Matt, you guys got to the Matt part, right? Multifocal atrial tachycardia. Yes. Treat the COPD. D is the only answer choice that speaks somewhat of management of exacerbation of COPD, right? So the answer here is D. Good. Perfect. So guys, if you didn't get that, don't worry. Let's talk about that. Let's talk about it if you didn't get it. So 55-year-old man with history of COPD. So they're giving you the history of COPD. And they tell you as the COPD gets worse, the palpitation gets worse. It says here, he's coming to the emergency department, fatigue, palpitation. That's what stands out the most here, palpitation. That's when they come into the emergency department. You guys, I don't know if you guys remember. I told you, if you see patients in cardio questions coming to the emergency department, chances are it is either MI kind of question or it's an arrhythmia type of question. If you see the word palpitation, you should naturally be thinking of arrhythmias. If you see chest pain, think of MIs. His palpitations are worse with exertion. So as the COPD gets worse, the palpitations get worse. They're mirroring each other in that sense. Current medications, ipratropium, albuterol, metformin. They talk about his smoking history. Yeah, they get into all his history. Then they basically give you the clues, the auscultation clues that he has an exacerbation of COPD. Now, this was the major line here. ECG shows varying PR intervals and multiple discrete P waves that have different morphologies in 1, 2, and V1. So let's take a look at how this tends to look. Normally, with the multifocal atrial tachycardia, you'll notice one thing in general: the difference of P waves. They tend to start to change. Look at the difference in the morphology. Right? You see a consistent difference in morphology, like 3 times in a row there. It's like, whoa, that's not normal. So they did say varying PR intervals. That was a very slick way to tell you that the rhythm is not good. RRs are not consistent. Rhythm is irregular. That's a very slick way to say it, because it makes us think about PR interval rather than RR. But if they're varying PRs, that does make sense. And multiple discrete P waves that have different morphologies lead 1, 2, and V1. So which of the following is the next step of management? Yes, you treat the COPD exacerbation and the patient gets better automatically. All right? Keep that in mind. You treat the COPD exacerbation and the patient should get better automatically. That is the idea behind that. Do not forget that. Do not forget that. Hopefully that makes sense for everybody. All right, let's continue. Let's continue. So far, these questions are pretty good. You just have to definitely get your diagnosis correctly. All right, let's look at this one right here. Let's take a look at this one. This next question looks pretty intense, right? Looks pretty intense. Let's see. I'll read this with you guys. Wow. Hold on, the chat kind of closed down. Let me open up the chat again. I don't know why chat keeps closing down. But okay. All right. So this one says, a drug that inhibits which of the following processes is most appropriate for this patient? So a 24-year-old man comes to the office because of a 3-day history of blisters on the right side of his mouth, accompanied by burning pain and tingling sensation. Oh my God. He underwent a liver transplant 8 years ago for hepatolenticular degeneration. Yes, Wilson's disease. Just in case you guys did not know, hepatolenticular degeneration is seen in Wilson's disease. And this word really helps us out, lenticular, because the lenticular nucleus in the brain is also compromised. That's why they end up having extrapyramidal side effects. All right, continuing though. Remember that the lenticular nucleus is the putamen, the globus pallidus, externus internus. All right, so current medications are prednisone and tacrolimus. Oof, tacrolimus. Okay, his temperature is 38, pulse is 78, respirations are 14, blood pressure is 120/80. Physical examinations shows the findings in this photograph. Well-healed surgical scars are noted on the abdomen. A drug that inhibits which of the following processes is most likely appropriate for this patient? What do you guys think? So, okay, I see D, viral budding. What drug do you think will give the patient, first of all?
No, D was for the previous question.
Oh, okay. Sorry. Well, what drug do we think is actually going to be used here? First off, what's the diagnosis? Let me start by that. Burning pain, tingling, definitely is happening here.
Is that herpes? Like acyclovir? Yeah.
Yes,
Like
yes.
herpes, right? Yeah.
This is herpes. Definitely, definitely classic type of herpes
Yeah,
presentation.
I agree.
HSV1, right? Acyclovir. Acyclovir, acyclovir. That would make the most sense. So in this question, what would you guys pick as the answer choice? Shabnal says B. Does everybody agree? B, everybody would say? Well, first off, how does acyclovir actually work? How does it actually work? What does it actually do? Inhibit DNA first. The answer here is A. It is A. I'll show you the different types of issues here. So first off, you do have well, first off, herpes we should know is a DNA virus, right? Herpes is a DNA virus and it replicates basically using something called viral DNA polymerase. All right. So acyclovir basically acts as a fake type of guanosine. It is a fake guanosine. So what acyclovir does is that it gets phosphorylated by the viral thymidine kinase of herpes. So herpes has viral thymidine kinase. So this fake guanine, which is really acyclovir, is given to these patients. And yes, it gets phosphorylated, which kind of legitimizes its structure. And what it ends up happening is that it gets added to the chain that's being created. So the whole viral DNA polymerase, let's say here we are polymerizing a new DNA structure using nucleotides, right? Pyrimidines and purines. We're using things like guanine, adenine. We're using things like cytosine, thymidine. But when we grab this fake guanine, let's put it red, and we add it to this structure, it doesn't have that 3 hydroxyl end that allows it to continue its actual synthesis. The result of this, of basically not being able to continue the chain, is chain termination via the inhibition of viral DNA polymerase. That's the classic type of treatment. That's what it actually does. That's normal. Now, I'll show you a couple of tricks here because what happens if, for example, acyclovir is not effective, and this is the thing about acyclovir, why is this such a good drug? It's because it's basically getting phosphorylated by the viral thymidine kinase. This is not getting phosphorylated in all our cells, right? It has basically affinity to this type of enzyme to catalyze this type of reaction. So the cells that have viral thymidine kinase are going to be affected the most by acyclovir. That's why there's a lot of patients that can take this as a like prophylaxis, like they take it without a breakout. You guys see what I mean? You can take it without a breakout because of this, because it's selectively picking these type of cells. Now I'll show you how things get a little more difficult, like in CMV, for example. Yes, let me show you. It gets a little more complicated. Yeah, this one here is okay. So if I show you this little chart right here, let's break it down. Acyclovir, virus specific, because yes, it's going to the viral, the host kinase, basically using the host kinase in order to phosphorylate. But drugs like phoscarnate, they already come phosphorylated in that sense, and they do competitive inhibition of viral DNA polymerase, actually directly inhibiting this enzyme. There is a difference there when it comes to that. Let me specify more. Yeah, this image here is not too good because they added way too much information, I feel like. Let me show you in a more simple way. They had an image on this on UWorld as well. Yeah, one of the like the resistant types of treatment of CMV, you'll notice that they actually are directly inhibiting. They don't not need to be phosphorylated. If the phosphorylation doesn't work anymore, this acyclovir type of drug would not really actually work. So you would need something that actually inhibits the enzyme itself, is what I'm trying to say. If you lose the ability, if the virus gains a resistance by changing this viral thymidine kinase structure, then you'll need something that bypasses this kinase function. That's where the other drugs like phoscarnate or ganciclovir tend to play a role. That's the idea behind that. Hopefully you guys understand. Here, for example, okay, I see you guys chose more like B, right? Nucleotide phosphorylation. That's how it gains resistance. It changes its ability basically to phosphorylate. That's the idea behind that. So acyclovir's guanosine analog definitely requires to be phosphorylated before anything. But yeah, does everybody understand this? Does this make sense? Does it make sense? Let me know. Let me know. So if the virus itself doesn't have this thymidine kinase structure, if this thymidine kinase structure is not working in that sense, that's when you use phoscarnate, because phoscarnate just straight up inhibits viral DNA polymerase. All right. All right. Let's continue. Cidofovir as well does the same thing. But anyways. So yeah, this is herpes. You can definitely find the idea that herpes here has affected this patient anterior lip area right here, right? Vesicular type of ulcers. Remember that if the patient has ulceration, vesicular ulceration at the level of soft palate back here, soft palate, we say this is what? Soft palate ulcerations, what did we say? What is it? Herp angina. Herp angina is caused by what virus? Coxsackie. Yes. Coxsackie A. Remember Coxsackie A. Mouth, foot, mouth. I remember foot, mouth, and throat, and hand. Yeah, foot, mouth, and hand. Yes, that's the idea of the herp angina. This is the mouth part of it. So yes, that's Coxsackie A. Definitely remember that. And that would be herpes if it's in the anterior surface. Remember that HSV1 likes to go back into that trigeminal ganglia, right? That's how it basically moves. That's the idea behind that. So keep that in mind, 100%. Hopefully that makes sense. All right, let's continue. Let's look for another type of question. Let's see. All right. So let's see here. We have this one right here. What do you guys think this answer would be? It says here, which of the following is the most likely cause of the intersex finding in this newborn if the karyotype is found to be 46XX? So there's in 8-pound, 6-ounce newborn is delivered vaginally at 39 weeks gestation after an uncomplicated pregnancy. Okay, it says here, APGAR scores are 9 and 9 and 1 in 5 minutes, respectively. The newborn is crying, has pink skin, and appears vigorous. So it shows a vagina, also a structure that appears to be a penis, with the urethra located at the base near the opening of the vagina. So chromosomal analysis is ordered. Which of the following likely cause of the intersex finding? So it's kind of like this patient has intersex finding in the sense of having some type of masculinization of the genitals at that point, right? What would we think is the answer here? C would make the most sense. Would make the most sense for sure. Definitely, because if you're looking at it, basically the higher level of androgens would cause this type of effect, right? The virilization. That's what would make the most sense. 5-alpha reductase deficiency makes no sense. Remember, 5-alpha reductase is an enzyme that turns testosterone into DHT. So that's not the issue here at all. If you look at the presence of the sex determining region Y gene, well, no, this patient has 46XX. Maternal androgen exposure, yes, because androgen exposure at the point where embryogenesis and development of primitive, or let's say, external reproductive structures are influenced by sex hormones. And if you have a higher level of androgen, you can definitely start to cause virilization, right? That does make sense. Increased concentration of Mullerian inhibiting substances. Now, this comes from Sertoli cells. You guys do remember Sertoli cells? Sertoli cells are responsible for, well, Miss Sertoli. Makes perfect sense. A Mullerian inhibiting factor, inhibin B, and then also spermatogenesis. So if we're looking at XX, if we're looking at XX, we wouldn't have Sertoli cells. So we wouldn't have an increase of Mullerian inhibiting factor. Plus, if you increase Mullerian inhibiting factor, you'll notice that the paramesonephric duct will not have proper formation. That's FUP. Remember, fallopian tubes, the uterus, and the proximal vagina. And this was not the issue. It says it shows a vagina, also a structure that appears to be a penis. It was more like external genitalia rather than internal. Patient did not have like a blind pouch or anything like that. So definitely that could not be the answer. And then A, that's more of a congenital adrenal hyperplasia type of issue. That, of course, was not the answer. All right. So definitely, let's leave it here. I think that was good. That's just a drill based on different types of subjects we were running through. Definitely, a lot of people do remember a lot of things, which is great. Definitely feel like we should be doing a lot more drills and loading them up all the time. Definitely. I would catch you guys next time. This week, we do have a lot of class. So we do have double sessions on Thursday and Friday based on older MBMEs. So get ready for that. It's going to be like 3 hours straight. Catch you guys later. Thank you for everything. And I would definitely upload